from Bangalore, and Shilpa is Kasoga ka ART committee chairperson. Priyanka is there. Hi,
Hi, good
Priyanka.
evening.
Priyanka is a very
Good evening,
dear,
everyone.
dear to us. She's Dr. Sheila Mane's daughter. Nice to have you. Take active participation in academics. Hemant is an embryologist. He's also from Bangalore. I don't know who is Gynae SBU, GYN SBU.
Sir, ma'am, Corona.
अच्छा ये शिवानी है.
Yes, ma'am.
शिवानी है. अच्छा.
So,
Then Rashmi Yogesh I'm seeing, Satvik I'm seeing. Rashmi is also from Bangalore. ठीक है.
ma'am,
तो
shall we start now?
हाँ 7 o'clock हो गए ना.
Ma'am, we are live on YouTube.
अरे चेयरपर्सन हेमंत तो आ गए हैं. Okay.
Okay, good evening, respected faculties and delegates present over here. On the behalf of Corona Remedies, I, Shivani Bhabra, welcome you all. So, I'm sharing the screen now. Okay, so it's my privilege to welcome Dr. Seema. Dr. Seema Pandey is a National Executive Committee member of ICOG and ICPAC and Commonwealth Association for Health and Disability. She is a co-author of A to Z of PCOS, everything you wanted to know about PCOS. And she is a art and fertility enhancing surgeries. She is a member of FOGSI Handbook of Drugs in Infertility. So I welcome Dr. Seema in Insights series.
Dr. Seema Pandey is a librarian for our National ISAR at present, and she's also the president of Azamgarh OBG Gynae Society. Welcome, Dr. Seema.
And I'm secretary UP also. These three are my designation. Rest
She's
everything is
secretary
secondary.
UP, Yes,
Yeah.
yes.
Thank you, Shivani. And good evening, dear friends, respected faculty, Dr. Anuradha, and Dr. Adiga, Manju, Shilpa, Harish, and everyone. On behalf of Insight Series Episode 4, I welcome you all to this program academic. Sorry, my voice is happening. Can you just, somebody
I
is
request everyone to
unmuted.
mute, please.
I welcome you all to this academic bonanza online, which Dr. Anuradha has just brought us in association with Karnataka chapter of ISAR. And I welcome Dr. Anuradha Khar for further proceeding as I am traveling right now. So, can I have the CV of Dr. Anuradha Khar? Apart from being my best friend, Dr. Anuradha Khar is Executive Committee member, National ISAR. He is Treasurer, Karnataka ISAR. And this year she is contesting for one more post, and I request and hope that she wins the position, and all of you will help her. And before we go for the prayer and she starts the program, I would like to hand over the stage to Dr. Anuradha. Please start the session.
So thank you, Dr. Seema. Thank you so much for a wonderful introduction. So firstly, we will start with our prayer. So let's start our sessions. It gives me very much happiness, and it's a privilege to introduce our chief guest of the day, Padma Shri Dr. Kamini Rao. Dr. Kamini Rao was awarded Padma Shri in 2014. She's a medical director, founder of Minan Fertility, and now she is also the director of Dr. Kamini Rao Hospitals in Bangalore. She's a pioneer in reproductive medicine and IVF in India, former president of ISAR and FOGSI, two big organizations of India. She did her fellowship in UK, and she's a renowned clinician, educator, and thought leader. Welcome, madam. Uh, our guest of honor is Dr. M.S. Srinivas. He is the past chairperson of embryology. Um, he is director and principal embryologist of Kerry Fertility Private Limited, founder president ACE India, course director MSc ART Mysore University, vice chairperson. He finished his chairpersonship as in ISAR Embryology, scientific director Narayana Health, past president of Karnataka chapter and ICMR expert committee member. Welcome, sir. Um, we move on to our first scientific session. Um, I would like to invite um our chairpersons, Dr. Ashwini GB, Dr. Manjunath S., Dr. Dilip Kumar, and Dr. Hemant. Can you display CV of Dr. Ashwini? Yeah, Dr. Ashwini GB. Yeah, she is the director, clinical director of Aspire Fertility Center in Bangalore. At present, she is our secretary of Karnataka chapter of ISAR. She did her education from Manipal, and her achievements are she has been awarded a lot of awards and a good leader, and her tenure as secretary Kesar has been wonderful. Welcome, Dr. Ashwini. Dr. Manjunath S. Yeah, he's chairperson. He is our immediate chairperson, Karnataka chapter is SAR 2123. He is the medical director, baby science, but which is now Birla Fertility, and he has a lot of academic achievements, social responsibilities of a fantastic leader. Under his leadership, I was the joint secretary, and we did South ISAR together, first time in south of India. And welcome, Dr. Manjunath. Uh, our next chairperson is Dr. Dilip Kumar. He's the chief embryology in Dr. Kamini Rao Hospital, Bangalore, and his area of research work in kinematics and effect of male gametes on development of embryo and quality control ART. He's authored several chapters in IVF and lab aspects of andrology, Infertility Atlas of Human Embryology. He is our executive member for KESAR at present. And let's have Dr. Hemant. Dr. Hemant. Yeah, Dr. Hemant is working at Genia Fertility, is the chief embryologist there. And Dr. Hemant is very capable and so helpful, actually. His results are very good in embryology. And welcome, Dr. Hemant. Uh, the speaker of, is Dr. Manjunath there?
Yeah, very much. Yeah, very much.
Can you introduce Dr. Chaitanya, please? Call the speaker. I hand over to you.
Yeah. First of all, thank you, Dr. Anu, for arranging this wonderful webinar, particularly on this less discussed topics. Thank you so much. And it gives me immense pleasure to introduce Dr. Krishna Chaitanya, who is a good friend of mine, and he's not only a good embryologist, who's a very good academician, and he took his credit. There are a lot of papers. I always wonder how he gets so much time to do the academic research also. So he did his Master of Clinical Embryology from Monash University and postgraduate in reproductive science from Monash University, Australia. Then he at Oasis Fertility, his main area of work is cryobiology, IVM, and currently is working on employing newer techniques to improve the success rates in in vitro fertilization in PCOD and recurrent IVF failures. Stage is all yours, Dr. Krishna.
Thank you for that kind introduction, Dr. Manjunath. Thank you, Karnataka ISAR chapter, for this kind
Hello.
invitation
Uh,
and giving this topic, because this is a topic that interests me a lot, and decades of work and research and publications, and happy to share all of that with you. So I'll just share my screen.
Yeah. So
And
Dr. Krishna Chaitanya is also the member managing committee of National Embryology.
yes. So let's get started. And yeah, if there are any questions, we'll be very happy to take at the end. So I'm going to be focusing more on what laboratory aspects, or what as embryologists we could do, and what we as clinical team need to focus on when it comes to severe male factor infertility. Always when we speak about male infertility, the first thing comes is medical management. And there's so many times, at least when I started off the career, the urologist or the gynecologist would say, "ICSI kar do yaar," what else, poor sperm, let's just do ICSI, or let's look at third party reproduction. But I think 2026, the science has so evolved, and let's just give it a quick look. So I think the five fundamental things: egg, sperm, embryo, uterus, hormone. And there's so much that we speak about: the ovary and oocytes, the hormones, the uterus, the female side of it. The science of embryology in the last 4 to 5 decades has really progressed much. But when it comes to the sperm, I think we are somehow limited, and we just don't seem to be thinking out of the box. And let's see where the science has evolved today. So we're going to focus on exclusively the sperm today.
Dr. Chaitanya, can I, 1 second, Dr. Kamni Rao has joined now.
Sure.
Madam, welcome to Insight Series episode 4, madam. It's a privilege and honor to have you. And madam, can we have few words from you?
Yeah. Thank
We
you,
would have
Anuradha. Can you hear me?
Yes,
Yes,
ma'am.
ma'am, we
Yes.
can hear
Yeah.
you.
Thank you very much. I know I'm a little late, unfortunately. It's been a real pleasure to join the Insight series. And as Anuradha always tells me, academics is in the blood of every person from Karnataka. And we have Krishna Chaitanya, who's been giving a very good lecture. I've just had a little glimpse of it. But Anuradha, as you had mentioned this earlier in the evening, that it is really full of absolutely, stuff that is fresh out from the academia rather than having a CME program. I wish the Insight series all the best, and may you have many more such series, because this is the only way that you will disseminate information across many, many cities as well as tier 2 and 3 towns, because these are the people who really need it a lot. And I think, you can make it more vibrant. And as I can see a large number of people having attended this, I wish this webinar all success. Thank you very much for inviting me. Okay. Thanks a lot, Anuradha.
Thank you so
Bye
much,
bye.
madam. Thank you.
Yeah. Bye bye.
Dr. Krishna, you can continue.
Thank you, madam, for that kind words and words of encouragement. Means a lot to a lot of us here in the field of ART. So let's move on. So, we all know that there's equal contribution of male infertility. Let's not dig further. So why not give equal importance? When we're talking so much about individualizing the female counterpart, the stimulation protocols to a lot of, hysteroscopies, laparoscopics, add-ons, everything happens there. So male seems to be a little neglected. So let's focus a bit more on that. I think this is what is the main strong message that we all need to take from this lecture today. What we're moving away is from the concept that there's severe male factor infertility, there's cryptozoospermia, or there's azoospermia, and we just want to take a very simple, easy option of third-party reproduction. There are so many options where donor becomes the Z option, and how is what this lecture will focus on. So what really changed? Why have we been able to offer the best success rates, even in severe male factor? Even if you have 10 or 20 sperms, we still sometimes manage to help a couple reach the other side, that's pregnancy. So I think, thanks to this wonderful invention, micromanipulation, without this, I don't think male factor infertility would have ever had the light what today it's having. Um, this whole science of surgical retrieval of sperms, both on the clinical side of how the surgeon has evolved to a point of now doing both medical management or doing microtesis, and on the laboratory side, how do you handle it? How do you ensure that you pick the right sperm and make sure that it's viable and inject it and have pregnancies and healthy live births? I think thanks to this whole technique of surgical retrieval, which has again in the last few decades undergone a huge improvement. If there was no cryopreservation, trust me, none of us would have been as successful as what we are today. So thanks to this lovely invention, it really adds, it's the cherry on the cake. It really adds a lot of glamour, and that's what is helping us with success. Without this developments in embryo culture system, so it is just not one aspect. I think it's been a collective effort which are ensuring and helping that male factor infertility is actually giving the success what it is. And I think all the developments in the embryo culture system, be it the media or the air quality or QCs that we're speaking, has really added on. And of course, not to forget, I think our deeper insights into the genetics and the molecular things about the male infertility is again helping us prognosticate and give better success rates. A little word of, I wouldn't say wisdom, but I thought this is the best platform to share some of my personal thoughts. This paper of ASRM 2021, we all know that, where it said, non-male factor, don't do ICSI. And whenever I meet my colleagues in international platforms, ASHRAE, Aspire, and all, you know, when I'm coming back, I have this feeling that we are 100% ICSI. I am also a part of it. Don't I have absolutely. Sometimes I feel bad to say that all my patients get only ICSI done. We as collectively as a community needs to fight this out wherever possible. If IVF is doable, I think we all as embryologists and clinicians need to look at it. That's one request and a thought from my side. If even countries like Korea, Japan, the Asian countries have now started doing IVF. India is absolutely not lagging behind in terms of technology or embryologists or the clinical acumen, and we should start thinking of using ICSI where it's indicated. Having said that, when there's severe male factor infertility, when people say, oh, what else can we do? ICSI itself is a treatment. ICSI itself is an invention for severe male factor infertility. We sometimes are overlooking this side and we want to do something out of the way. I'm like, go step by step. The severe male factor infertility, you're putting the sperm directly into the cytoplasm of the egg. That itself is a treatment. Can you see what happens with the cycle? Rather than putting a lot of add-ons in the basket in the first cycle itself. I also have very enthusiastic clinicians who want to put too many things into the basket in the first cycle itself, and I somehow don't like that. But severe male factor, do I do ICSI or do I with self sperm, or do I directly go offer third party reproduction? I think this is the dilemma which used to be very common probably 2 decades ago, but slowly now I think we look at self gamete conception. But what are our challenges and fears when there is sperm count less than 5 millions? There's cryptozoospermia, or you have testicular sperm. As embryologists, as clinicians, I think we're failed fertilization. What are we going to tell a patient tomorrow? I got 15 eggs and nothing's fertilized. Or on day 3 or day 5, you're going to cut a sorry face and say, oh, I did all of this for the last 2-3 weeks, and unfortunately I have no embryo. Or finally you put back some embryo and there's a negative outcome. I think let's put these points: failed FERT, cycle cancellation because of no utilizable embryo, or a negative pregnancy. So I think before we really start off, let's first see what is the world saying. What are these KPIs? And sometimes, are we really over expecting from a cycle? We need to realistically come down and put our expectations to the right scientific KPIs. And thanks to Vienna in 2017, which says that, doesn't matter. This is unclassified. I'm not saying there's severe male factor or female factor or anything, but in general, if you're getting a fertilization rates in between 65 to 80%, I think as a lab, you're doing fantastic. I'm not saying we'll stop, but you're in a decent zone. So if a lab has, let's assume, a 78% fertilization rates, there's scope to improve, but I don't think that team has not done great job. What is the incidence of failed fertilization? It's only less than 5%. That's what the globe is reporting. And looking at blastocyst conversion, it's in between 40 and 60%. If we're expecting 80% blastocysts from a particular cycle, even in third-party reproduction, it will not happen. You're doing embryo donation, donor egg, donor sperm. Sometimes you're not going to get 80% blastocyst conversions there. And finally, when you put an embryo back, even with a blastocyst, it's 35 to 60%. And you have audited your results, and let's say you have an implantation of 58% in the last year, 2025. Bingo, you've done a fantastic job. What are you expecting? Okay, you want to go to 65%, then okay, what else can we do? There's always the next level you could go. So I think you need to audit your results, compare, have your own KPIs defined for your lab, and that tells you how to improve. So, failed FERT, no blast, and pregnancy outcomes, what does the literature has to say? And this is, again, when we looked at male factor. So this is a lovely paper of 2023, 19,000 IVF cycles. And look at the incidence. This is all retrospective data. This was a Korean paper and no, Chinese paper. And look at their overall incidence of total failed fertilization that they are reporting. It's around about 7.5%. And then they actually went and divided it into people with normal semen parameters and a bit of low semen parameters, still 6 to 9%. In their group, 21% of total failed fertilization was reported in people who were poor responders, and most of them had 1 or 2 eggs. And we know that when you're getting only 1 egg from a stimulated cycle, it can fertilize or not fertilize. Now, I don't think that's an outlier, and you should be trying to troubleshoot such a case that's in front of you. So I think bottom line, the incidence of failed fertilization, even in severe male factor, is still in single digits. So, anticipating that there's going to be a failed fertilization and offering donor sperm, not the best option. Blastocyst is something that we all want to do, extend blastocyst culture. So when there's severe male factor infertility, what does the evidence say? I just looked at the evidence in the last 5 years. It's been a little mixed. Some reports saying that it could be a little lower, and most reports saying that it's all on par in between 30 and 60%. I think thanks to the improved culture systems, lab practices, sperm selection techniques that have actually helped get us almost 50 or 60% blastocysts there. So the take home here is, I think you need to avoid just having those statements saying that, oh, it will not work. Severe male factor, don't do extended blastocyst culture. Let's put 2 or 3 embryos. Patient safety, what patient needs, I think we need to look at it. Severe male factor infertility doesn't become a dire indication to put back 3 embryos or just do a cleavage embryo transfer or look at a donor sperm transfer. The data of leaving them for external blastocyst culture seems encouraging. That's the summary of that. Now,
Dr.
just
Chaitanya, sorry. Dr. Srinivas is there. He
oh,
has to go
sure, sure.
somewhere. Just, I'm sorry I interrupted you
No
twice.
problem.
I really
No problem.
apologize. We have Dr. Srinivas, who is our past president KISAR, and he is also past president. He's past chairperson embryology national ISAR, and he is the founder of Kerry Fertility Center, and he trains embryologists. After sir started the training, lot of good embryologists we are getting, not only in Bangalore, all over India. Welcome, sir. Welcome to Insight Series episode 4, sir. I would like to have few words from you, sir.
Okay, namaste. Uh, First and foremost things, I'd love to know hear know Chaitanya's the talk. Okay, he is really touching upon very important the subject that is male factor and assisted reproductive technology. Can you hear me?
Yes, yes, sir.
Okay.
Yes.
So this is a very important no subject really for all embryologists. Whenever we doubt male gamete, the straight away we think that no, we'll have to counsel it for donor insemination. So now we were able to retrieve even a few sperms are there in testicular biopsy, microepididymal sperm aspirations, and there are some male factor improvement can come through the clinical activities actually, so that we need not have to counsel the patient for to go for donor inseminations. So this is where no I don't know why it has been interrupted. Please continue, Chaitanya. I'll listen to you, then finally we will no conclude it.
Thank you so
Thank you
much.
so
Thank
much.
you. Thank you.
And most importantly, you know that Kisar is going to make a new team, and many of them are contesting this no, year. Okay, I will wish all of them good luck, and specifically Anuradha, who is contesting for secretary post. Thank you so much inviting me as an guest of honor.
Thank you, sir.
Lovely. Thank you so much. It was an absolute pleasure to be having interrupted with two stalwarts there. So let's continue with it. So we spoke that the incidence of total failed fertilization just because there's very poor sperm counts didn't seem to be alarming. Blastocyst conversions also is encouraging. Now, the next question is, just because you have very poor sperm or using testicular sperm, would the embryo aneuploidy go up? There are times where you're putting blastocysts and pregnancy is still not happening or there's miscarriage. Is male factor a reason? And for a very long time, even I was convinced, because if going back to the basic science, epigenetically, if you see, it's the sperm that's influencing the trophectoderm formation and the placental formation. So there was a hypothesis which still is there. People haven't proven that in severe male factor infertility, since the placenta is going to get affected, there are going to be a lot of placenta related diseases. So IUGR miscarriages is something that might go up, but they're not proven. And that is where this whole idea comes, would severe male factor infertility, low sperm counts increase the aneuploidy in the embryos? There's so many papers which have looked at it. And in fact, look at this 2025 paper, which has looked at, oocyte donor cycle. So the female factor is completely kept at a bay. Even there, I don't think the aneuploidy went up. So male factors correlation with the ploidy of an embryo doesn't seems to really be a concern. So it's more the maternal age, maternal factors, which probably would influence the ploidy. And that is what the science right now is telling us. Now let's look at the clinical KPIs, your clinical pregnancy, miscarriage, and live birth. So severe male factor again. So this is again from a meta-analysis that was taken in 2023. So the clinical pregnancy per embryo transfer cycle is in between 30 and 50%, because it's just not the sperm. We know there are so many other factors that's going to influence a pregnancy outcome. So the average is 30 to 50%. Live birth from as low as 20 to 45%. I think now we all want to cumulatively look at the live birth rates, because that is what is going to speak about the efficacy. And I think when there are favorable female factors, this meta-analysis says the cumulative live birth is 40 and it could be as high as 75%. So, that's well within the KPI of what VNS says. So I think, the miscarriages are not going up, the live birth's good, the clinical pregnancy is something that we would want. So I think severe male factor infertility is not something that's detrimental to the clinical KPIs as well. So that was the intro and the background there. So, okay, we all want add-ons and interventions. We want more. The patient in front of us should just get the best, and we want the cycle to work. So, with that background, that thought, what are the additional interventions or add-ons people have tried, and what is the experience? And I would probably put in a bit of my experience as well here. So I think let's first look at this paper. This is nice paper. I like it in Asian Journal of Andrology, where they looked at somebody with an obstructive azoospermia, cryptozoospermia, and very low sperm counts, that is somewhere between 1 and 5 millions. And would it really influence the fertilization, cleavage, and good quality embryos? So the last two columns, if you see, I think the cleavage or the good quality embryos was all the same, whether it was the testicular sperm used or very few low quality sperms. I think it did give a decent outcome. That's what this paper said. And this is a concern which was simply answered by this paper of again a Chinese group, where they did a sibling oocyte study, severe male factor, very poor sperm, half eggs with self sperm and half eggs were injected with donor sperm. And then they looked at the fertilizations and cleavage and good quality embryos. And this paper was a landmark paper which said, this sibling study did not show that use of donor sperm enhanced the availability of good quality embryos. So, somebody who's just coming for a first time, and then you have some viable sperms to inject. We're doing ICSI. If there are 10 eggs, you need 10 viable sperms. And if you have them, how can you say this might not result? So even without thinking of third party answers. Now, I'm not against third party, but I think you need to justify it, only indicated we do this. So this paper was something that really goes against the use of third party, and why not? I think everybody deserves a self gamete consumption. Next is the concept where people said, oh, low sperm counts, why don't we go do TISA or micro TESI in them? And this is something that whenever I interact with my own embryologists in my team or my fellow colleagues, juniors at times, they have a lot of preconceived thoughts. Oh, testicular sperm, nicer, ferts kam honge iske, blast nahi aayenge iske. There's so many things, and look at what the literature says. So I'll just take you quickly through a lot of papers where they have tried and seen in a particular scenario use of testicular sperm and how the outcomes have changed. So this is cryptozoospermia. So we all know crypto is initially you put a drop, there's no sperm, you then pellet down. You probably are going to get some 20, 30 twitching or a bit of motile sperms. That's crypto. In a pelleted sample, you're going to get. And this is a meta-analysis by Craig Niederberg's group. So, they then went and said that, in cryptozoospermic patients, use of teaser sperm is preferred over the ejaculated sperm. So it did help improve a lot of KPI. So for cryptozoospermia, you really want to add on, do something additional. Doing teaser is something that you could consider. Next, this is a situation where the first cycle you've probably crypto or 1 million, you've done ICSIs and it's failed. The second cycle, would additionally we could do if the patient has come back to us, we probably could convince them for a teaser, because again, why it's not really answered, but I'm assuming testicular sperm has got lesser DNA fragmentation, a better DNA integrity, and it's not increasing the aneuploidy risks. Your KPIs are better. So in a second cycle, use of teaser seems to be justified when there's severe male factor infertility. Now, in this particular paper, looked at the non-azoospermic indications where you could do ICSI, which is crypto and severe oligo. And again, they said that the KPIs seems to be better. So there are so many publications which are focused on use of testicular sperm when there's severe oligo, crypto, and azo per se. And most of them are trying to put the same thing. The laboratory KPIs and also the clinical KPIs are maintained. So what is our concern? Our concern probably is, oh, it's teaser sperm. How do I go about? I think there is a significant room for improvement of embryologists of how do you handle this surgically retrieved testicular tissue in your laboratory. For me, if the clinician doing a good job is important, what equally important for me is my team in andrology lab, which does a magical work in processing it. I want a clean prep with no RPCs, no debris, with a cohort of nice motile sperms. The life of an embryologist is just going to get easier. And my own embryologists in my own team, my colleagues, they say, oh, sir, very less sperm. What are you expecting in a testicular retrieved sample? It's not an ejaculate. I'm sure, India being a country of 100% ICSI, we are so used to those ICSI dishes where you put it, you see plenty of sperms moving here and there. You just want to quickly pick sperms, put in the egg, and start the next case. What is the rush? Why in a race? And such cases is where you as a senior embryologist has to make a difference. So stretch your back, put some pressure on the back, spend some time, pick the right sperm. Your outcomes are going to be all the same. So this was our experience at Oasis, that we did micro-TESI for cryptozoospermias. This was presented at ISARIAN in 2023 at San Antonio. And look at this, 79 patients where we counseled the patients. They were okay to get a micro-TESI done. And I was also skeptical, does such bigger surgical intervention really required? But the quality of sperms that you're going to get when you do a micro-TESI is definitely better. I understand you need a surgeon, you need a good operative microscope, you need a full-time andrology team which can, look at multiple samples. Micro-TESI isn't easy. But look at these people. In 79, almost 31% had live birth rate. I didn't have an alarming miscarriage rates that we saw in the cryptozoospermic patients. So that's another add-on. And if available for patient, it's quite beneficial because there's minimal blood loss. It's, you get a direct visualization of dilated tissue. So that's something that is helpful. So overall, lab aspects of, if you're really considering doing teaser for severe male factor infertility, on the right hand side are your important topics. You need to tease your tissue well. You need to ensure you've done your best to get rid of the RBCs. Now, do not shy away from using a calcium ionophore. Theophylline is now commercially available. I'm not propagating a commercial company out here, but I think the only commercial company right now selling this in India is Gynemed. We routinely and regularly use this. I don't think I've seen any kind of risk. But again, is this for everyone? No. If you're really having absolutely no motile or twitching sperm that you see, as per the protocol, add a bit of calcium ionophore and you will see some twitch there. You've got to put in some extra effort, you will get the right sperm. So what I do is I sit and I search those 15-20 sperms, and then that 15-20 sperms, I then look at morphology. For me, the first criteria is viability, a bit of twitch. Then I pick morphologically normal ones and I do ICSIs, and the success is on par. Fresh and frozen testicular tissue, there's no difference. Again, this was presented at SRM with 100 odd patients. And so as an embryologist, I think you do a wonderful job. If you could ICSI and cryopreservation in a male factor, you can make a huge difference out. So this was the only or the first Indian paper which published this. It was at Decades Experience, where I used to always hear people saying, "Oh, testicular sperm, they're going to create problems, less blast, more miscarriages, less live births." And our data of 10 years, we said it was on par. Ejaculated sperm or testicular sperm, the outcomes were comparable. And we tried and ensured that the female factor was taken care of here. So we have an Indian citation that we could proudly quote. That's our experience, but we've published it way back in 2023. The next thing, so in severe male factor, we looked at the role of ICSI, which is all good. The KPIs are good. Then we looked at use of testicular sperm. That's encouraging. Now the role of cryopreservation. It's improved heaps and bounds. Again, somebody with a cryptozoospermia where I only see some 50 motile cells, should I freeze it? That's our concern. And the science has evolved. So I'm sure I've got another 10 minutes or so, or 7 minutes to wind up, Dr. Anuradha. I don't have too many slides after this. So I think,
Yes. Please continue, because
again,
even I want to listen to this.
I'm not
Freezing or not freezing.
propagating this particular device, but for a very long time, because we do a lot of micro testes at Oasis. So doing a regular cryo or a sperm straw freezing was not giving me the best survival. So we were then looking at these micro devices. There was Japanese thing called a cell sleeper. We used the regular cryotops. We used zona pellucidas. None of them were giving me the best outcome. And then I got introduced to this Israel team, Berkowitz team, and this kind of works well. Again, I don't want to propagate anything. It is with the intermedics guys. If you want to look at it, it's not very easy. There's a little learning curve issues because you have to put all your sperms in a 1 microliter drop, but not rocket science. Works well. I think this is a regular SOP for us. Works pretty well. So, somebody with a cryptozoospermia has some 20 twitching motile cells, doesn't want donor at all. Let's respect their choice. What we do is we just go collect this 20, 30 motile cells, put it on this device, we freeze it, we thaw it, we do ICSI with that. 10%, I've never had an instant where I've never had a live sperm after I've thawed the device. I do get twitching sperms. The fertilization probably is 10% lesser, but I've never had cycle cancellations. But again, it's in double digits. It's yet to be published. We are on the verge to actually publish this data on this particular device. But the point I want to make here is these cryptosperms, what you've got, the freezing techniques have evolved, and it's not rocket science. When we can do biopsies and ICSIs, these things are not rocket science. You just need to put in a bit of effort, train your team, and there you are. So what does the literature say about the frozen sperm in these severe oligozoospermias? Are there survival issues? Some papers said, there could be, but again, it's a mixed thing. But overall, if your strategy of freezing is all good, you got to go work, individualize, and come up with your own SOP what works. And then trust me, it's all good and rosy there. And when we looked at the KPIs with these, frozen sperm and very low sperm count people, the FERDs or incidence of total failed FERD, blasts, miscarriage, live birth, again, they do not seem to be concerning. So the signs of cryo has again helped the severe male factor people here. The last concern, severe male factor, would DFI be raised? Poor sperm, so DFI also probably is going to be poor. So that's why we don't want to do anything. Let's go with donor sperm. So people did look at it. So there's again some papers saying yes, the DNA integrity comes down, but there's so many papers which says they do not. So the take home message here is in severe oath samples, there could be some amount of compromised DNA, but your embryologist plays an important role. Your meticulous sperm handling and sperm selection during ICSI is probably going to nullify that risk that we all are thinking about. So we got to keep that in mind, that sperm DNA fragmentation, is there a correlation with very poor sperm counts? I think it's still not proven, so we don't have to conclude saying somebody with 1 million sperm count has a bad DNA. I don't think it's. But I think DNA fragmentation increases as the paternal age increases. If there are a lot of lifestyle factors like a BMI, chronic smoking, binge alcohol, I think these things are going to definitely influence. But low sperm counts, the effect is not proven. You know, okay, somebody with very low sperm counts, what are the advanced sperm selection options that we have in our reach in India right now? Well, in IMSI, you can, if you have 20 sperms, you can do IMSI on that. But again, it's very controversial about will it enhance the outcomes? But if you have the technology, yes, it does help you pick. Let's say I've done micro TESI or TISA and I've got some 20 viable sperms. If, my clinician has invested into IMSI, it definitely helps me pick the best morphology sperm and it can add on. So that's one thing. Microfluidics, something that we all are, it's such a fancy thing. We all want to do microfluidics in our lab. And there's so many people who say that, oh, anything less than 5 million, it will not work. So we specifically did a pilot on this, and at this ESHRE, we have sent an abstract. So 1 million to 5 million. If you have some 10% of even non-progressive mortality, we load it and we do get recovery. And what are you looking at to do ICSI? You need some 10 or 20 sperms. So you will get it. 2 to 5 million, definitely recovery has been there. There are times that a 1 million sample did not give me a recovery. So our recommendation is, right now, anything less than 5 million, don't do it, is not something that's going to work. But what's important is having some motility in your sample. Microfluidics can be done. We spoke so much about the role of TISA, but Pixie Max, anything less than 5 millions, I don't think is a great idea. We all know right now in India, Max distribution has been stopped. So Pixie is still there, but you've got very low sperm counts. I don't think Pixie works very well. So with very low sperm counts, it's IMSI, microfluidics, or TISA. TISA any day is going to give you better sperm. If as an embryologist, you have cracked an SOP of how to handle them and freeze them, your KPIs are going to be well maintained there. So that's the last slide. So I think with ICSI, when I'm doing cell sperm, the incidence of total failed fertilization is less than 10%. The FERTs are between 60 and 90. The BLASTs are about 40%. There's no tagline that DNA will be fragmented and your clinical KPIs seem to be all good. There is Indian data which says use of testicular sperm does give you the best clinical KPIs. So donor should not be our option when there's severe male factor infertility. As an embryologist, we need to focus more on sperm processing than sperm selection. There's a lot of options available there to freeze and pull up these crypto samples and of course do teaser. Thank you so much for this opportunity, Kisar. And the floor is all open for questions.
Thank you so much, sir. Dr. Chaitanya is always wonderful and rejuvenating listening to you. Anybody has any questions? I think there was a question in the chat box. Any sperm selection method you will advise for ICSI for oats sample? I think you have answered it.
Yes,
Doc,
so you'll have to
yeah.
look at, do you have some motility? Again, first of all, ICSI itself is an intervention. Do not overlook and say ICSI will not give me the outcome. But let's say a patient is coming for the second time. Again, do you want to use a microfluidics? It is not backed up with enough scientific information. In a forum like this, I don't want to say, oh, microfluidics is the best, go use it. There is only one meta-analysis and it's only speaking about raised AFI. So severe male factor, low sperm counts, is microfluidics the answer? I don't really want to give away that kind of a statement. You want to use it. It does help you with, good KPIs of FERTs and blastocysts, but you'll have to individualize it. What you need is motility in the sample. No motility, microfluidics will not work because it has to channelize your sperms.
Do you have any other questions?
I have something. Can
Yeah,
I?
Dr. Ashwini does embryology also. I knew she'll have a question. Okay.
Hi, thanks, Anu. Hi, Dr. Krishna. Excellent talk. I was listening to it thoroughly, end to end. The last few sentences was intriguing. Max distribution is completely stopped in India, you mentioned, but even recently I got every
I think
people.
there's a lot of challenge in getting this, ma'am. It's, I've had couple of instances where they've given me a near expiry kit. I think, and especially when the kit comes to near expiry, your recovery is going to be a little concern, and especially your DFI is very high. I didn't see a beneficial thing out there, but I think the distributorship is causing a lot of challenge to us.
Actually, we use from Shivani Scientific. Yeah, I think so. It is Shivani Scientific. I can't offhand remember,
It was
but
SAR
we
last when I had was taking it, and then we had so many issues that we kindly gave up. And then we did our own RCT on teaser versus max for raised DFI, which is published in JARG, and we didn't see a benefit. So
you're doing still teaser for high DFI.
I'm not saying, okay. So the first RCT of, this is a total different discussion. The first RCT was teaser versus max. There was no difference. So we continued and we did a forearm where we added microfluidics and daily ejaculation. And again, we had no significance in all the forearms. So we do say that, TISA is a surgical intervention. It's invasive and it should only be exercised when indicated. And I'm of that thought as well. But somebody with very raised values, now our clinicians are of the thought that why don't we do teasers, because it's directly taking it from the site of production. But I'm not really endorsing anything out.
And I feel in that condition, maybe we should try and
So
avoid.
this,
And
I'm hoping Eshrey will say yes, but there's a paper that we have. So we looked at all the DNI cases, which was 50% and above. And we had two subset. One went for teaser, one went for microfluidics. And we actually didn't see a difference. Our clinicians saying that 50% and above, let's do teaser. Surprisingly, even with microfluidics, I was getting blasts and the implantation miscarriages are
no, don't you
comparable.
think? Sorry to interrupt you. Don't you think we should actually compare them with the conventional methods like a density gradient rather than
Yeah,
comparing
we've done
two
that. We've done
experimental
a double density arm, we've had a microfluidics arm, and we've had a TISA arm.
and across
Uh,
all three you didn't find it?
all three, and we didn't actually find a difference. The miscarriage in microfluidics was the least, which I think is expected from microfluidics because it really channelizes sperms with good DNA integrity. Theoretically, we all know that. But yeah, TISA is something that of late even we have started to question its role. But until I think backed up by adequate RCTs and meta-analysis, right now I wouldn't want to make statements that it will not work. It does have a role. It is very
So yeah,
subjective
I think
because your
yeah,
embryologist needs to be competent enough in handling it. The
true.
embryologist
Yes.
is going to make a magic here.
Several factors I think will come together to actually prove it's useful. I mean, it's very difficult to act, frankly speaking, and that's why also possibly research is so slow. I mean, it can be considered fast, but it's still slow. The fact that past 10 years, I think from 20% pregnancy rate, we are at least at 50-55% now, and going forward it will improve. But then because the confounding factors are so many in the lab, yeah, it's difficult to prove what is helping us.
Absolutely right.
Thank you for your talk. It was
Thank
very
you
good.
so
So
much.
thank you, Dr. Chaitanya. Thank you for sparing your precious time. And I've heard your talk in Aspire, and I was really moved by those your papers, what you presented, and that's how I started going to Aspire. And we'll be going to China also to listen to you. So we move on to the talk two now. Our talk two is on again on oats and intratesticular PRP, and the speaker for this talk is Dr. Is Dr. Kedar Gandla. But I would first like to invite the chairpersons for this talk, Dr. Nivedita Shetty. She is our chairperson KISAR at present, and she is done her FRCOG from London. She is director of IVF unit of Manipal Hospital, Mysore. and she is a very academic person, I would say. My second chairperson for the day is Dr. Lavanya Kiran. She is the director and lead consultant, and she is a robotic surgeon and of KIMS Institute, KIMS Hospital, Bangalore, and she's a fertility specialist and also. So there's a lot of feathers in her cap. She's a TEDx speaker. She's too good, and she is the vice chairperson of Karnataka chapter at present, and she's going to take over next month as the chairperson of Karnataka. Welcome, Dr. Lavanya.
Thank you, Dr. Anu.
Yeah. My next chairperson is Dr. Shilpa Harish. She's senior consultant IVF specialist, Satvam Fertility and IVF Center, and her area of interest is PCO, poor ovarian reserve, and she participates regularly in webinar. And at present, she is our Kasoga chairperson for ART committee, and I am her secretary. So we've done a lot of interesting IUI workshops and a lot of webinars. Welcome, Dr. Shilpa.
Thank you, Dr. Anu.
Okay.
Dr. Nivedita, would you like to introduce Dr. Kedar? Please, can you
Yeah,
display that CV?
that's an honor. Yeah.
You're the chairperson, so.
Yes. It's an honor to introduce Dr. Kedar Gandla. He's always been a very, when I was secretary of Karnataka State, he was the secretary at the All India level, and we've interacted very often, and it was great knowing Dr. Kedar. So listening today, he's going to have a very interesting talk, intratesticular PRP for oats. Does it help? So we're waiting to listen to Dr. Kedar. Lavanya, you want to say, yeah? Can I see the slides? Yeah, just a minute. Yeah, he's also, yeah,
Yeah.
can I?
While he's sharing his slides, Dr. Lavanya, I want to talk something.
I think Dr. Kedar is a very wonderful clinician as well, very meticulous in his protocols and taking care of patients. Quite a few of his patients come over, so they have very good words for him. And while the CV is still coming, all the best, Dr. Anu. I think we're all in support of you. Would urge everybody to vote and participate in as many votes as possible. All the best to you.
Thank you, Dr. Lavanya. Dr. Shilpa, you want to speak something while he's.
Very
Dr.
novel
Kedar,
topic,
please share your screen.
It's not seen.
Important topic and
No.
doable.
You cannot see my slides.
No.
We can see your folder. It's an entire folder.
Entire folder is seen, but not your. You have to start your slides. Dr. Shilpa, you continue.
Yeah, this will be a doable thing, and if it is improving the sperm recovery rates, nothing like that. I would love to listen to your talk, Dr. Kedar Gangla. Welcome.
1 minute. Stop share. एक मिनट रुको. Can you see the slides, please?
Yes, sir.
Now you can see a slide.
First slide you can see now.
Yeah, it's your
So
screen.
make it in the slide mode. Slide mode डाल दीजिए.
Yeah, अभी देखा है?
Perfect.
Yeah,
Perfect. Okay. Fine. Thank you very much, Kisan. And it's one of the societies where I always like to go to Bangalore to give talks. I always feel in South India, you give a lecture at 8 o'clock in the morning, the hall is full till 4 o'clock. And like North Indians, the hall gets time to get filled up later on. So the topic of male infertility, I started researching from last almost 15-20 years when I realized there are hardly 3 or 4 andrologists in say Mumbai city, and the andrologist would look from a different perspective than the IVF consultant would look at the male infertility patient. And to get an appointment, sometime it used to take one month. So I started looking at my patients on my own, and I started reading about it, and this is how it will go. Sorry, something is wrong. 1 minute. Sorry. Now it's okay. Can you see the slides? Hello?
We can see, sir. We can see.
Yes, sir.
Yeah, okay.
Yes, yes.
So,
We can see.
as a male factor, we know it's responsible to about 50% of infertility. And out of that, oats is responsible to about 16 to 20%. And what happened is, what Madam was saying is correct. With the advent of ICSI, very little attention has been put on surgical, medical, as well as the lifestyle modification required for the rising level of male infertility. If you've seen from 1973 to 2018, there has been dramatic fall in the sperm count as well as the motility. And this could be because of the exogenous sources, which I think is on rise. If you see last 20-25 years, is these all activities like environmental pollution, radiation, unhealthy diets and lifestyle, which are responsible for it. Whenever you consider the age, they used to think that the man is the finger, man is the ring in the finger, finger is the woman, finger will get older and the ring never gets older. But now the science has proven that men above 45, especially with comorbidities like obesity and diabetes, can have abnormal sperm. Their job profiles can affect something like heat and radiation can cause injury to the sperm. Rising level of diabetes and hypertension. In our OPD, we see about 30% of the patient below 40 are having hypertension and obesity. Lifestyle, I think smoking and tobacco are the two important factors which are responsible for male infertility and increasing sperm DFI and causing erectile dysfunction. So radiation, as we know, that we always thought that the radiation would be the cause, and these are the way the radiation would affect the sperm, the testes. Now, the problem is the radiation is they cause distortion of the head and mitochondrial sheath and leading to apoptosis. Since we cannot prove it, it's like, you have a cold drink, Pepsi, Cola, or pizza affecting the obesity and you cannot link it. This will never be able to link it and say that this is the cause of this and it should be stopped. Mobile phones. So the ultimate of mobile phones is the electromagnetic radiation, heat and ionizing radiation. The answer was given that to keep the phone in your shirt pocket and not in the trouser pocket, so that you will die of heart attack and not of male infertility. Now, this is what I was talking about. As the age increases, there are increased chances of genetic defect in the child. And if you look at the right side corner, the research has shown that there is increased level of autism, schizophrenia, and psychiatric morbidities in the offspring, especially if the male is above 45 years of life. Smoking, we don't have to say that it was one of the tobacco and smoking is both main cause of affecting the sperm count and increasing the DNA fragmentation. Alcoholics also have a problem of decreased DNA fragmentation, and plastics. I think something which we all need to look at. We have been using the plastic since last 20-25 years. And this is the mechanism by which it all affects. It starts from the childhood and it continues as we age. Cross-sectional studies have shown that the multiple microplastics were found in utensils, cooking utensil and food contacts, and these would affect the significant reduction in the total sperm count and sperm concentration. Now, majority of time when you tell the patient that stop using plastics, the already damage has been done. And there was one paper which found that they actually found microplastics in testicular tissues. When infertility, you diagnose infertility and you say a male, you have a low sperm count, is it associated with lot of psychosexual problems? But generally what I've seen in an infertility clinic, though it's a IVF clinic or IUI clinic, male is remembered only on the day of collecting the sample. And that because of the male psychological issues, they could be a performance anxiety, erectile dysfunction, and could lead to decreased frequency of intercourse. Having a relation only at the time of ovulation could result into a infertility. So erectile dysfunction and premature ejaculation in OATS patient you can find in 1 in 6 patient, and orgasmic dysfunction you can find in 1 in 10 patients. So I think most important thing is a detailed semen analysis and has to be done from a standardized laboratory. This I always insist that many times from a local laboratory a count is done, it says that it is a normal, and then the male is dumped on one side, and high level of investigations to extent of doing histolaparoscopy has been done. When later on, when the patient is sent for IUI now to level 1 clinic, they actually realize the problem is in the male. If the male is above 35, I always do a sugars and lipid. This is the count of 2021. And what do I mean by standardized laboratory? That it should have a good microscope, sperm counting chamber, and a person sitting behind it should be able to analyze it correctly, because there are hardly any junior embryologists are opting for this kind of work. Now, the diagnostic modality, that is semen analysis, is actually based on evaluation of sperm concentration, motility, and morphology, are poorly standardized. Means there is no actually proper standardization. Like if you see WHO, this manual, entire Southeast Asian sampling was not done in their WHO 2021 manual. Subjective means who is seeing today Tina, Meena, Hasina looking at the microscope and giving the report, and definitely not powerful predictor of fertility. Means a man who is having a sperm count of 5 million, wife is young, both are young, having good regular sexual contacts, can have a normal pregnancy, and somebody who's got a huge count, but he may not be able to initiate the pregnancy. So hence, I think total motile sperm count is something which is very important, especially if the pre-wash sperm count if is more than 5 million, then only one should attempt an IUI. If it is less than 5 million, one should try to treat this man, get his count above 5 million, and then treat with IUI. If anything less than 5 million should be referred to the IVF center. So if the count is at 10 million, volume is 2 ml, and motility is 30%, which gives up counts of 6 million total motile sperm count. Now, you just reduce the count and the total motile sperm count goes to 2 million, and the person will be required ICSI. And if the motility is improved, you will get total motile sperm count is 20. Definitely, you can try IUI. Now, the new AI which has come in the market, I also tried it, and this has a very little capacity to analyze between the pus cells and the immotile sperm, and hence the motility and the count sometimes can be a difficult choice. The problem is high cost, job replacement, and lack of transparency and accountability. And the advantage is that at least it will give some accurate results with consistency. And I think definitely I understand that as the time will progress, they will become more precise in giving semen parameter analysis, which will help you in quick diagnosis and treatment decision. Some of the parameters like lateral head movement and these are little, I think, will require more long-term studies to understand. The other one is a hypoosmolar sperm function test, where the tail of the sperm will get coiled when they put in normal saline, when the sperm is alive, and when the sperm is dead, you will not see this coiling. So this will tell you how many sperms are live and how many sperms are dead, so that you can pick them up for doing ICSI. DNA fragmentation. So in India, the DNA fragmentation is done with the halosperm, and which is the least sensitive and specific test. The most commonest tests which are done in the where publications are accepted are done by tunnel method. So I think the two arms of the DNA get separated, and this DNA fragmentation happens, resulting into the abnormality in the factors, which result into, if the DNA fragmentation is less than 30%, you will get a better pregnancy rate in IUI. If it's less than 30, you will get a better result. With IVF-ICSI, DNA fragmentation can be overcome. Again, with high DFI, whereas in male infertility, if untreated, you will get higher chances of abortions. So miscarriage. So one need not be happy that your patient conceived or beta ICG came positive. It is this abortion rate is something which is very disturbing in terms of high DNA fragmentation. So clinical pregnancy is rare, but there can be high risk of early abortion and associated with negative abnormalities. So you have a DNA which is not repaired. When you fertilize with the oocyte, if there is a partial repair because of the oocyte, a normal offspring will produce. And if it's not produced, an abnormal offspring will be produced. So what my previous speaker said about evaluating the female factor is also important in terms of the fertility potential has to be ruled out. So additional diagnostic tests, something like DNA fragmentation has a new horizon, and this can help in identifying the patients with high DNA fragmentations. So now the optional tests, these are something which is very, very important. If physical examination or a color Doppler to rule out varicocele in standing position with cough impulse, if you seen a very visible mass at the inguinal region, then it is a grade 3, grade 4 varicocele, which by doing the repair will produce good results. Karyotyping only in patients with below 5 million sperm count. Again, with below 5 million sperm count, you should think about doing Y microchromosome deletion. So genetic testing can be done in the form of severe odds, Y microdeletion, and Y microdeletion, if it comes the mutation at AFZA and AFZB, likely cause is going to be the azoospermia. If it is AZC, then the person has oligospermia, and this in these patients, the FSH will come normal. The count may be 2 million. One should expect an FSH to be high. It is not will happen. It will the FSH will be normal, and then treating this by medical condition will not improve the count. So there is no point if a patient has Y chromosome microdeletion AFZC, then one has to freeze the sample, and that will help. So you do physical examination, investigations, analysis, if required DNA fragmentation, hormonal assay only if the count is less than 5 million, that too serum FSH is which is very important, karyotyping and Y microdeletion and a scrotal ultrasound after physical examination. So if the count is between 10 to 50, is mild odds, less than 5 million on two different occasions at 4 to 6 weeks apart from a standardized laboratory, then it is severe odds. The treatment would be lifestyle factor improvement. Something about lab factor, which I always think, shorter the abstinence, better is the outcome. Collecting directly into the media helps in not allowing the seminal plasma to interact with the sperm. In a batch IVF, I have seen the samples are collected before the oocyte retrieval, and they are utilized 3 hours after the sample, the oocyte collection, which makes sure that the seminal plasma will destroy the sperms into the jar. Maybe using Pixie and IMSI or MAC can be helpful. So does daily sex helps? If you look at go back as 100 years from now, it definitely showed improvement because that time the family size was 10 without knowing time of ovulation. But the only thing was early age of marriage was the only answer. When you have a very, very short abstinence, say 4 times ejaculation will reduce automatically 20 to 25% of the sperm DNA fragmentation because it reduces the duration of the transit of the sperm from the epididymis and exposure to ROS. This is a very old paper. In 2009, it was produced in Amsterdam. 118 men were told to ejaculate for 7 days without giving drugs and no lifestyle changes. What they found, 80% of the men showed improvement in the semen parameters. As we know, lifestyle parameters, something like rising level of obesity. Now, to understand the male is obese, the gynecologist has to think about it and has to treat the male. This I did during the COVID time, and I found 4 or 5 patients showed a fantastic improvement, and half of them had a natural conception. Otherwise, they would have landed with IVF ICSI. So this particular study, their 100 infertile men tried to study the lifestyle factors like after smoking alcohol, smoking, and increasing physical exercise. And they found this healthy lifestyle improves the sperm DNA fragmentation. Now, the only problem with us is that telling a man to reduce 10% of weight, or for that matter, female, reduce 10% of weight, they just do not want to wait. And our fear is if they don't wait, they will go to somebody else. And somebody else will not tell anything like this and just go ahead and do the IVF. So I think is the first line approach in any obese or any lifestyle modification required person. So if obesity disorders, it can cause systemic inflammation, insulin resistance. Another thing which I have to worry is genetic and epigenetic changes and leptin resistance. Obesity will cause erectile dysfunction, increase scrotal temperature, and alter seminal plasma. The bigger picture of obesity can be in the form of muscle inflammation, liver inflammation, adipose tissue inflammation, testicular inflammation. All these would appear to decrease the normal sperm count and increase sperm DNA fragmentation. And the obesity, which has a detrimental factor in this particular paper of 2025, as the BMI increases, sperm quality will gradually decrease. Now, how many IVF center actually check the blood pressure of the husband? On top of it, check the height and weight and calculate BMI to see whether the male is actually requires any modification, or for that matter, andrologist. I personally feel that hardly anybody does that. And this will result into a abnormal sperm, and this negatively affects the outcome of the. This is the fantastic picture I think I have put on my consulting room, that lose weight and have a good pregnancy outcome in form of this is the way we hide the obesity in men in India. The paternal obesity, I have tried telling couple of patients to go for pediatric surgery. In European standard, European country, a lot of people undertake the pediatric surgery, and they found there's a significant improvement in the sperm parameters with azoospermia and oligospermia. Then comes our favorite treatment options of antioxidants, antibiotics, hormonal agents, and surgical intervention. So when you have count in between mild and moderate, generally the clomiphene citrate and tamoxifen or aromatase inhibitor or gonadotropin application, does it help? Let's look at it. This meta-analysis published in 2015 suggests that in unexplained oats, giving clomiphene citrate not for 25 days, giving for 30 days suggests that associated with increase in sperm count as compared to placebo. Now, according to me, this would help. Obviously, you will treat this is the only count, but the quality would be treated by something else. This will help the embryologist for a natural conception. In obese men, we know because of there is continuous conversion of testosterone to estrogen, and estrogen will cause suppression of the FSH, leading to decreased FSH. Letrozole effectively increases in improving the sperm parameter in extremely obese individual, especially in oats or non-obstructive azoospermia is found to be very effective. Now, 8 studies have been done with using recombinant FSH, where purified FSH was used in 150 or sometimes 300 IU. 2015 study, and this shows in the chart that completely in the favor of treatment group in terms of count, motility, and morphology. All these shows and ART pregnancy. So all these shows using gonadotropin in unexplained oats patient would help. I realize this importance of this is there are certain communities in Muslim, say Bori Muslims, they need to take a permission of their master and they are allowed to do only after IUI. And these are the patients where I used FSH and had a significant improvement in the sperm parameter and pregnancy outcome. So FSH helps in the European clinical guidelines suggest that FSH has a potential benefit in improving the qualitative and quantitative sperm parameters. Now, as we know, role of antioxidant, there is an ROS. ROS required for lots of activity, but if the ROS is increased, will result into damage of plasma membrane and cause DNA fragmentation. And these two things, which are very important, the DNA fragmentation and the motility, will affect the outcome.
Dr. Anusha, please mute.
So this will make the sperm vulnerable for DNA fragmentation. And these are the factors which are responsible for DNA fragmentation. So this is the paper in 2014 where giving antioxidant not only improves the outcome, but improve the live birth rate. Not only outcome, but the live birth rate was improved by giving this. Now, when you look at the antioxidants, I have not selected the newer ones because still the data has to be out. These are the ones with the strong recommendations for giving improving the outcome, and these are the ones with the weak recommendations. Sometimes I feel if folic acid is required for a female, I think male also require folic acid as common sense as possible. So combination is what is recommended. When you look at the evidence A, if you see coenzyme Q10 in the dose of 100 to 600. Now our combinations are giving only 100 milligram. So it has to be given at least twice, or CoQ 300 has to be given. Carnishore is again has evidence B, improving the sperm motility and N-acetylcysteine and vitamin E. Rest has evidence number C. So the reactive oxygen species has helped in improving the capacitation, hyperactivation, acrosomal reaction, and sperm fusion. And if you have excess ROS, it will affect the outcome. And these are the antioxidants which will help you to improve the outcome. So one of the paper also says in 2023, overconsumption of antioxidant can lead to reductive stress. So what happens is the patient first time goes to one IUI center where he receives a combination of L-carnitine, coenzyme Q10, goes to the second doctor, he'll change the combination, but again he'll give the same thing. Third doctor, so the patient is on 50 rupees tablet every day for last 1 year. And I think this needs a very, very balanced approach as antioxidant therapy is concerned. Now, many patients have a count which is say 15 million, 20 million, but A grade motility is 0%. Now, it could be because of the structural defect or genital tract infection or varicocele or idiopathic, and treatment could be in the form of antibiotics for a long period of time, CoQ, L-carnitine, and repeated ejaculation, and if required, varicocelectomy, which will improve the cellular level of improving the outcome. Viagra is a drug which can be used 50 milligram. More than 50 papers have been published till now, in vivo and in vitro, both places, which improves the sperm parameters to improve the sperm motility. Now, when you give 50 milligrams of Viagra 2 hours prior to the sample collection in a patient who has got oats, they found there has been improvement in the sperm motility as compared to the baseline. And this has been done by our group also. We have published one paper where we showed there has been improvement in the motility after taking sildenafil citrate. Now, again, I would say this would definitely help patients who with very low sperm count and non-motile sperm for an embryologist to select a better quality sperm that will improve the outcome. This is how the charts show. Now, the new drug on the block is the myo-inositol 2 grams. So again, we give myo-inositol 550 milligram. This is 2 grams of myo-inositol helps in improving the sperm quality, especially the motility, the progressive motility, if you use it for more than 3 months. And again, one in vitro study, which is coming up again in 2025, whereby if you use the saffron, okay, the saffron, which help in improving the sperm motility. Now, lots of papers are talked about probiotics in female. There is one group in us also who are working on probiotics in male infertility. Well, it will take a little while for coming out of the consensus. Surgical treatment, I think varicocele ligation is something very important. The important factor to be remembered, lack of testicular atrophy, normal FSH, and count at least has to be 5 million when you give a choice of varicocele, and a patient who is not very close to the medical therapy for regular checkup can be given for varicocelectomy. So these are the causes. One of them is hypothermia and renal metabolism. Instead of going up, they're going down. This is the way the grade 3 visible, palpable at rest or in standing position. And the standard approach, subinguinal microsurgical approach with the loop, seems to be the most rewarding because it helps in sparing the lymphatic and testicular artery and improving the sperm outcome. Old paper improving the outcome to 33% as compared to 15%, but as good as new papers at 2025. Varicocelectomy helps in improving the semen parameters and allows the men to undergo IUI. Many people or many patients, you operate them, leave them alone. If wife is young, they are intercourse, they will come back with a normal natural pregnancy and higher clinical pregnancy outcome. Again, in IUI, now when you go to IUI for subfertile male, it is very important to not to stimulate the female with letrozole or clomiphene. Use gonadotropin. Use at least 2 to 3 follicles. Then only this IUI will help. Well, there is no difference found in between the whichever technique you use, the swim up or density gradient, it doesn't matter. Now, the only study where it shows the double IUI in male infertility patient helps in improving the outcome is the male factor. Initially, it was thought to be in the research process, but this multicentric study has shown it helps in improving when you do a 2 IUIs, either pre-rupture and on the day of the rupture or on the rupture and the next day, helping the outcome in terms of 2 IUIs. This study favors double IUI in terms of outcome. Now, semen cryopreservation, something which is very important, and my previous speaker has already spoken about it. My only thing is, when the patient is in testicular failure, rising FSH, please do not wait for other medicine to act. Ask him to freeze a sample, which is very important. Patient having performance anxiety, please ask them to collect the sample in between the interval so they do not have difficulty in collection on the day of IVF ICSI. Donor insemination, I think ejaculatory dysfunction, azoospermia, and genetic defects, other things. But I think the most important for donor insemination, the sample has to be taken from ART bank. One, every time you do insemination, you have to take the consent and you have to save the consent form. Every 3 monthly, you have to take HIV, HBsAg, HCV, VDRL for the patient. And most important, this has also to be done in level 1 or level 2 clinic only. Please do not try to do insemination in your clinic after getting the sample. And the last thing is, the sample procurement has to be done by the patient itself, and we should not be doing the sample procurement for the patient. So it is the responsibility of the ART clinic who has to obtain the sperm from the ART bank. Now, when you have couple of with OATS, first look at the maternal age and the severity of the OATS, and look at the psychosocial factors and socioeconomical status. Now, if the person is from a very, very low socioeconomic status, the option of giving a donor insemination is justified. I feel it's very justified. But if he's from correctable format, previous to IVF failure with grade 3 varicocele, I think one should be giving option of varicocele surgery. Young couple, one medical application, simultaneously treating the woman, simultaneously treating the man. Severe OATS, I think you will have to refer to the ART outcome. Mild to moderate OATS, confirmed by 2 samples, do serum FSH and blood sugar. If the FSH is elevated, patient is going in testicular failure, do semen freezing and IVF. If it's normal, proceed the same way. If the blood sugar, this is something which we often miss, looking at the blood sugars. When the patient is young, please do the blood sugars and clinical examination to rule out varicocele. Now, if the FSH is normal, lifestyle modification, antioxidant, and minimum for 3 months with frequent ejaculation, then give gonadotrophins, 2 to 3 follicles, try 2 to 3 cycles of IUI with a break in between. And if you want to refer them for ICSI, please send them for where sperm sorters have been used. Severe OATS, again do FSH, elevated, freezing, normal. Try gonadotrophin, unlikely it will work. Y chromosome microdeletion present, sperm freezing because it's not going to improve. Negative, send it for IVF with sperm sorter. Now, how do you reduce the DFI? Short abstinence, you improve the outcome, it will improve the DFI. Oral antioxidant, any study ranging from 20% to 66% showed reduction in the DFI. Varicocelectomy, sperm sorters has been also tried. And look at the testicular sperm. Fantastic. It helps in reducing the sperm DNA fragmentation. Now, this point is something which is very important. OAT sample and a oocyte. Young patient, say 10 to 12 antral follicle count on each side. Good quality oocyte, you were lucky to reach here. But if this patient has endometriosis, unexplained infertility, low AMH, low count, low sperm motility, you will land up with abnormal sperm or abnormal embryo, and result into early pregnancy failure because you will do the transfer on day 3 without telling the patient what the embryo quality is. So my concern is about the low AMH, diminished ovarian reserve, poor oocyte competence, endometriosis, advanced maternal age with male factor with previous IVF failure, one should considering donor oocyte option to improve the outcome. This is from a clinical outcome and also from 2025 paper. Ideal sperm for ICSI is a testicular sperm. When you do TISA, you're likely to get success up to 50%. Micro TISA up to 67%, you will likely to get pregnancy. And when you do a medical therapy, before doing TISA, you're likely to get 72% higher chances of getting sperm in the sample. Now we come to the interesting part is the effect of intratesticular injection of autologous platelet transfusion of IVF outcome. Now, these are the patients who have failed one micro TISA and two micro TISA. After first failed micro TISA, they underwent PRP and they found 21% of this patient were found to have sperms with live birth rate of 10%. Now, that is something amazing, and previous two would up to 2.8%. Now, again, this paper from 2024, effect of testicular platelet plasma, improvement in the sperm concentration up to 16 million, morphology improved, sperm motility. Look at more, they found that the biggest advantage were in terms of improving the sperm motility and reducing the DNA fragmentation of the sperm. So post PRP, I think the sperm concentration motility increased and DFI was decreased and testosterone was increased. So our experience with intratesticular PRP, which is published, accepted for publication, 41-year-old lady with male with one live birth 8 years back, trying to conceive. The count came as occasional motile, non-motile. HbA1c normal, BMI was normal, microdeletion Y chromosome absent. So the mechanism action of PRP is releasing these factors, these neurotropic factors. VEGF, I think it's important for in terms of sperm motility and velocity. So this is the way we did DNA injection. So with the help of this 26 number needle, we injected 0.05 ml into 10 to 12 compartments of in the different parts of the testes, which I did it under anesthesia. But if you have a good urologist, this can be done by doing cord block also. And it doesn't require anything else. It just becomes a little firm. You give a testicular bandage. Next day, the patient will be as normal as possible. So in our case, the FSH from 20 came down to normal as 9. The count from occasional motile, non-motile came to 14 million, and the motility improved to 45%. So this is the count done before the PRP, where you can see occasional motile, non-motile sperms. And this is post PRP. You can see significant improvement in the seminal parameters. So I'm not suggesting that every person or every patient should be given. Actually, they need a thorough evaluation, and that is what is going to decide this therapy is going to work. It should not be happening that, we are injecting PRP for patients of low ovarian reserve, and that is not happening. So intratesticular PRP increases the cytokine and growth factors, which will help to improve the outcome by, this is our first case, whereas in secondary testicular failure, we could show improvement in the sperm parameters. And this has been accepted in Journal of Obstetrics and Gynecology of India. And like varicocele, it will help in downgrading the disease. The IUI may be conceived with spontaneous pregnancy, and patient require IVF may conceive with IUI. I am not the authority. I think multicentric trials are required. And I would like to end with this small video. I think it's a little longer video. Anuradha, can I play this video?
Yeah, sure.
It's a very motivating video, I find. This is an old man staying alone. It's around the time of Christmas, and he decides something, goes to his attic and finds a weight. Again, next day he gets up, early morning, motivation, and does exercise. Keeps doing almost every day. Till the day arises, on the day of the Christmas, he takes this lovely gift to his granddaughter. Here's the most important part. Just see his action. I think it's something important. If you love your subject, this should make you get up early in the morning and read. Read for the science, read for your patients, and read to improve the outcome of all those patients who are coming to us with standard therapy. Thank you very much for your time.
Thank you so much, Dr. Kedar. It was a wonderful revision for me, actually. And that intratesticular PRP was good. I hope a lot of us will get motivated to try that out with the proper patients who fall into that category where it may help. Dr. Lavanya does a lot of intra-ovarian PRP. She's a laparoscopic and robotics surgeon. So, Dr. Lavanya, any comments you have?
Yeah, I think, sir, it was really wonderful listening to you. I think it was a very thoroughly walkthrough for all of us on the oats and then the PRP as well. I just had few questions, and you were talking about all the bariatric surgeries and all. With the present GLP-1, do you still think bariatric surgeries would still be relevant for obesity for men as well?
I think first thing is to diagnose and identify or address the issue of obesity in male first. Do we have that attitude also? And then on GLPL1, again, you will require 3-4 months of intensive therapy to lose weight, at least 10 to 15%. And then you may see an improvement in the parameters. So as generally with obese male, there will be obese female. I think both of them will require the treatment, and then only we'll have to go. Effect of GLPL1, I was speaking to Jaideep, and Jaideep Tang said people have conceived on GLPL1 and they have formed a group and they are following it up, and till now no abnormalities have been found. Anyway, there are no embryological studies have been done for this drug.
But I think GLP-1, they say you should stop at least a month before they plan conception.
I know. The pharmaceuticals will be on the safer side, but there are people who conceived on GLP-1 and continued the pregnancy.
So one word on this electromagnetic chairs. Any experience for all this erectile dysfunction for the men?
I think we are looking at the problem at the wrong end. The problem is between the 2 ears, not between the 2 legs. I think something is wrong there only. Especially I will tell you a story in Mumbai. The husband wife stays in, somewhere outskirt, travel for 2 hours, 4 hours a day, work for 12 hours. After going home, the bheja is completely fried. The last thing they have on their mind is to have, sex. And very poor falling frequencies of sex is happening in this married couple after second or third year. I think they have to be told that you please improve upon this to improve the count. The real erectile dysfunction with associated with, say, diabetes or some psychological issues, I think that has to be understood first. And then I think very few patients where the blood flow is reduced, which is maybe should be diagnosed with penile Doppler, and then I think you should put them for electromagnetic chairs. This is my opinion. I have not
No,
referred any patient till now. Yeah.
So
True,
thank you,
true.
Dr.
I
Kedar.
think PRP was very good.
I think the topic
PRP
is
study
too
was
big.
good.
Yeah, topic is
So
too
it is,
big
it is,
to be
it is.
finished
And
in
we
such
have a
a
testicular failure. So I'm inspired with your PRP. So we will try and get back with the results. Hope your study motivates us and gives us a good result. Thank you so much for it. It was really enlightening
Thank you.
for us.
Thank you.
Thank you, Dr. Kedar.
Anuradha, thank you so much for giving this opportunity to me. Lovely. It's so nice to see Nivedita and everyone here again. Thank you so much.
It's been a pleasure having you here, and especially your crisp points, take home message. Thank you so much. We move on to the next session, a rapid fire. We wanted to do quick, short questions, 20 questions in 20 minutes, because we are a bit late, 15 minutes late. So the moderator for this session is Dr. Prashant Adiga. Can I have his CV, Dr. Prashant's? Shivani, are
Good
you there?
evening.
Yeah. Okay,
Yes,
Dr.
ma'am, it is on
Prashant,
the screen.
I can't see. There's a folder. There are a lot of folders there. I think it's Dr. Kedar's folder.
Yeah, I'll stop sharing. Okay.
Yes. So Dr. Prashant Adiga is a good friend. He is head of the Department of Reproductive Medicine in Manipal. A very academically oriented person, as all Manipal consultants are. A lot of research he's doing, a lot of papers he publishes, and I requested him to prepare some questions for our panelists. Can we have the CVs, please?
Ma'am, now is it
Yeah.
showing?
No, Dr. Kedar, you have to stop sharing, I think.
I stopped.
Ah,
Ah,
no, Dr. Prashant has started sharing, right?
ah.
No, Dr.
Yeah.
Prashant, can you please, do you have the panelists' CVs? No, you
Yeah.
don't. So
I
you
have
please,
shared sorry, first of all, my sincere apologies because the internet is not really very great here, but I hope I'm audible.
Shivani, please give.
You are audible, Dr.
Is
Prashant.
the,
But I think
yeah.
Dr. Anuradha wants the CVs of the
CVs of
panelists.
everyone we
Stop
want.
sharing. Yeah, so stop
He has
sharing.
Yeah, what I
In
will do
other
is, I
minutes, you will
think
come back.
Yeah,
I
Dr.
request
Prashant
the
is.
panelists.
Yeah, let me finish it. Dr. Prashant is Professor Head Department Reproductive Medicine Surgery, KMC Manipal. He's got Imaging Science Award in the year 2007. He's done fellowship in Advanced OBG and fellowship in Reproductive Medicine at KMC Manipal. Very national and international publications, and he has written a lot of textbooks. Welcome, Dr. Prashant. Can we have the CVs of our panelists, please? Yeah. Dr. Prashant?
I have some internet problem here.
Okay, I will take over. Okay, no
I
problem.
will,
Dr.
yeah,
Rekha, are you there?
I request the speakers to introduce themselves so that it will be
Dr. Rekha,
easier.
few words, one sentence about yourself, please.
I'm the KISAR EC member. I'm the medical director of Chandana Hospital and Miracle IVF, past president of Bangalore OBG Society.
Okay. Next is Dr.
Yeah.
So what we have done is this time is, since it's Karnataka chapter of ISAR, it's not limited to Bangalore. And that's what we have done here. Dr. Rekha is from Bangalore. Dr. Nagesh is from Tumkur. Dr. Nagesh, please introduce quickly.
Yeah, myself, Dr. Nagesh, practicing in fertility IVF since last 13 years. I'm based in Tumkur.
And Tumkur is my husband's hometown too. district too. So moving on to the next one, please. Yeah, Dr. Satvik, are you there? Please introduce yourself.
Yes, ma'am. Good
Yeah.
evening, everyone. This is Dr. Satvik Metkud. I'm a practicing gynecologist and fertility specialist practicing from Belgaum.
Okay, so we have one consultant from Belgaum. We move forward. Okay.
Hello,
Sujay,
everybody.
please introduce.
I'm Dr. Sujay Herangel. I'm a consultant OB-GYN and fertility specialist at Herangel's IVF Shirur Hospital, Bagalkot.
Wow. And next is Dr. Vidya. Yeah, Dr. Vidya, are you there?
Yes, yes. Good evening,
Yeah, please
everyone.
introduce.
I am Dr. Vidya Onwad, practicing infertility consultant in Hubli, Spandana Hospital and Janani Fertility Center.
Yeah, welcome. Next CV, please. Yeah, Dr. Channa, are you there?
Yes, ma'am.
Please introduce.
Yeah, I'm Dr. Chandana Bhatt. I'm a fertility consultant, currently the clinical lead at A4 Fertility Center, Bangalore.
Okay. Next, we have Dr. Shaviz. Yeah, please display. Yeah, Dr. Shaviz.
Hi, good evening, everyone. I'm Dr. Shaviz and I'm working at Nova IVF in Bangalore.
Next is Dr. Anu Sadashiv. Can we have? Oh, Dr. Rashmi Yogesh. Okay, Dr. Rashmi, introduce yourself. Okay, Dr. Rashmi is the clinical director of Kushi IVF Center and she belongs to Bangalore. Next CV, please. Yeah. Dr. Anu,
Good
are you
evening,
there?
all. Yes, ma'am. Good evening, all. I'm Dr. Anu Sadashiv, working at Millen Fertility, Kumara Park, Bangalore.
Next is Dr. Priyanka. Yeah, Dr. Priyanka, please introduce.
Good evening, everyone. Good evening, ma'am. I'm Dr. Priyanka. I'm working as a consultant in Milan Fertility, Kumarapa, Bangalore.
Okay. And I think that completes our list. Over to you, Dr. Prashant. You can share your screen now.
Thank you. Thank you, Dr. Anuradha, for the opportunity given. I think there are stalwarts before this presentation and I think now in the rapid fire also there are a lot of stalwarts. And fastest finger first will be the person. These are all basically very easy questions. I'm sure most of you will be able to, or everybody will be able to answer. Okay, here we go. So devascularization of the fibroid is seen in all of the drugs except one danazole, GnRH agonist, C mifepristone, D clomiphene citrate.
Clomiphene citrate.
Clomiphene citrate, right. That is the right answer. D is the right answer. Second
Host is muting us repeatedly. Please don't mute. Host is muting us repeatedly whenever.
Okay.
I am
One second.
unable to remove this.
Okay, ma'am. Dr. Shivani, please don't mute anyone because it's a rapid fire. Okay.
I don't want this. I am unable to read the entire question.
I will read it. The
Yeah.
necrosis, question number 2, the necrosis of myoma is from center because blood supply is from capsule, pseudocapsule, myoma bed center.
Pseudocapsule. B is the
Dr.
answer.
Rekha has answered very well. It's the pseudocapsule. Next question.
Which of the following is a cause of infertility in adenomyosis? Decreased free radicals, altered uterine peristalsis, altered desudalization because of deficient estrogen, and altered cervical receptivity.
Altered
uterine peristalsis. Altered uterine peristalsis.
Yes, altered uterine peristalsis. Right, that is the right answer.
Good.
Question 4. What is the recommended window for starting progesterone for luteal phase support? A. 24 hours prior to oocyte retrieval. B. Between the evening of oocyte retrieval and day 3 post-retrieval. C. On the day of embryo transfer only. D. Once a positive pregnancy test is confirmed.
B.
Yes, it is from the time of oocyte retrieval and 72 hours till you have a window where you can start the progesterone support.
Next question.
This again, which of the following? I'm sorry, I'm unable to read because
Should
of
I
this
read?
band. Yeah,
According to the 2023 International Evidence-Based Guideline, which of the following is correct regarding the diagnostic criteria for PCOS in adults? Anti-Mullerian hormone can be used as alternative to ultrasound for detecting PCOM. Ultrasound remains the first-line diagnostic tool for adolescents within 2 years of menarche. A follicle count per ovary, FNP, of 12 is required for the diagnosis of PCOM using high frequency, more than 8 Hertz probes. Clinical hyperandrogenism is mandatory for diagnosis all phenotypes.
AMH is
Yes.
Yes.
Right.
Yeah.
Then, okay, why is it not moving?
Question 6.
Okay. Based on the ESHRE 2022 guidelines on RPL, that is recurrent pregnancy loss, which investigation is not routinely recommended? A. Testing for Apla syndrome. B. Screening for hereditary thrombophilia in the absence of a personal history of VTE. C. Parental karyotyping after individual risk assessment. And D is assessment of uterine morphology using a 3D ultrasound.
B. Screening of
Yes.
hereditary
There is no need for screening for
Thrombophilia.
hereditary thrombophilia, as it is very, very uncommon in the population, unless it is a Norwegian
personal
population where
history.
the incidence is very high.
Yeah, the other three have to be done. You have to
Yeah.
rule out Apla, you have to do a karyotyping.
Anuradha, I need your help.
Ultrasound.
Yeah. Question number 7. A 30-year-old patient with stage 3 endometriosis and infertility undergoes a laparoscopic cystectomy. According to ESHRE 22, what is the recommended post-op strategy to increase the chance of spontaneous pregnancy? A. 6 months of GnRH agonist add-back therapy. B. Immediate attempt at spontaneous conception or ART avoiding suppressive hormonal therapy. C. Post-op just for 3 months. D. Routine second look laparoscopy at 6 months.
B.
B. Immediate attempt at conception.
Spontaneous conception.
Months of GNRH.
There is no
Yes.
role for waiting
There
is
period
no role
because there is a possibility of recurrence, right?
I would add that at stage 3 endometriosis, I am not waiting for spontaneous conception. I am doing.
Yeah, right.
IVF
You
will be
agree?
better.
It is direct ART. If mild, it is
I will
IUI.
do ART
Go for
because the
IVF.
stage 3
Yeah,
endometriosis.
probably it will depend upon the EFI. Yes, as you
Correct.
rightly said that in
And
grade 3
stage-
endometriosis, the EFI is likely to be very low.
Yeah.
And plus also most of these patients with grade 3 endometriosis, the AMHs also will be low.
Yes.
Yeah.
The fertility potential of that patient, the ovarian reserve, many of times will be low. I mean, most of the times I would say. So better
And the
Direct
additions also contribute to the loss of tubo-ovarian relationship.
Yeah,
Correct.
so
The-
EFI, basically EFI is going to assess everything, including the tubal function.
Yes.
Okay, that is where EFI comes into picture, right?
Okay.
Then, so again,
According to the
help.
WHO lab manual, what is the lower reference limit for total sperm mortality?
Mortality
32%, 40%, 42,
42 and
58.
58.
42.
42.
Okay.
Total is 42.
Become 42.
Okay.
40%.
Fine.
In a fresh embryo transfer, which statement regarding luteal phase support is true? Progesterone combined with HCG is superior to progesterone alone for live births. Subcutaneous progesterone is less effective than vaginal progesterone. Vaginal progesterone and intramuscular progesterone show comparable live birth rates. LPS should be continued until 12 weeks of gestation in all IVF pregnancies.
C.
Vaginal progesterone.
Vaginal progesterone and intramuscular progesterone show comparable live birth rates.
I agree.
A patient with symptomatic adenomyosis is preparing for a frozen embryo transfer, which pre-treatment is supported by the highest level of evidence to improve the clinical pregnancy rates. A. 3 to 6 months of ultra-long GnRH agonist suppression. B. Preoperative laparoscopic cytoreduction of adenomyoma. C. High-intensity focused ultrasound ablation. D. No treatment, immediate FET with hormone replacement therapy.
Ultra-long
Ultra-long.
Yes, 3 to 6 months of ultra-long GnRH agonist suppression will help in reduction of the uterine volume and the pregnancy rates are better. Again, I need your help, Anu.
Regarding question 11, regarding the 2024 consensus on fertility preservation, which of the following is true? OTC is still considered experimental and should be performed in research settings. OTC is the only option for fertility preservation in pubertal girls undergoing gonadotoxic therapy. Oocyte cryopreservation is superior to OTC in patients with high risk of ovarian metastasis. OTC requires at least 2 weeks of ovarian stimulation.
B.
Yes. So OTC is the
Prepubertal
only
girls.
option for fertility preservation in prepubertal girls undergoing gonadotoxic therapy.
So what about option C? I think even that is also true.
Ovarian tissue.
See, we are
Option
talking
C
about
is
ovarian.
OTC is ovarian tissue
Tissue
cryopreservation.
cryopreservation, yes.
Yeah.
these two are two different scenario, I feel, B and C.
Yeah.
Yeah, for these are
Yeah.
prepubertal girls, no? So oocyte
Yeah,
The
this is
prepubertal oocyte
oocyte
Whenever,
cryopreservation will
see,
not happen, so better
no,
have
the
the
problem
tissue.
comes when there is a high risk of ovarian metastasis. Probably again, oocyte cryopreservation comes into picture.
Yeah, this
Okay.
B you are particularly mentioning about the prepubertal girls,
Yes.
whereas
Yeah.
in C you are mentioning about ovarian metastasis.
Yeah. Okay.
Next, question 12. We are doing pretty fast. I'm happy.
Yeah.
Question 12.
Why is this stuck?
Yeah.
A 30-year-old man with infertility has the following semen analysis: low ejaculate volume, acidic pH, absent fructose and azoospermia. The testicular size and serum FSH are normal. What is the most likely diagnosis? Primary testicular failure, hypogonadotropic hypogonadism. It is congenital bilateral absence of vas difference, and D is retrograde ejaculation.
C.
CDAV.
Yes, the fact that it is a obstructive azoospermia.
Yeah.
It's an obstructive.
Fructose negative.
Yeah.
Fructose negative.
Yes, it is normal.
So there are a lot of things here. One is low volume, one is acidic pH, because generally it's more 7.4 to 7.6. Another is absent fructose, of course, azoospermia. So when you see an analysis report, you have to see all the parameters. Yeah. Next question, 13.
Which of the following test explains the mechanism by which HCG induces ovulation? Direct stimulation of FSH receptors, induction of endogenous GnRH surge, LH-like activity leading to resumption of meiosis, D, inhibition of aromatase in the dominant follicle.
LH-like activity.
LH-like activity. HCG and LH are structurally similar.
NHCGR receptor.
Yes, the alpha subunit is similar. So that is how it is going to bring about the resumption of meiosis. In hormone replacement therapy, HRT FET, which of the following finding is considered the most predictive of adequate endometrial receptivity? Serum estradiol level of more than 200 picograms per ml, endometrial thickness of more than 7 millimeters, the presence of trilaminar endometrial pattern, endometrial secretory changes corresponding to the progesterone exposure.
Presence of the trilaminar endometrial pattern.
C. Presence of
C followed by D.
C. First we confirm C.
Endometrial receptivity is only when there are exposure to, the receptivity becomes, it becomes receptive only when it is exposed to progesterone. So D will be the answer. Endometrial secretory changes corresponding to progesterone exposure.
What about all of the above?
There is no nota. All of the above is not there. Okay. So according to the X-ray guidelines, which markers are recommended for predicting high and low response ovarian stimulation? Female age and BMI, basal FSH and inhibin B, AFCs or AMH, and D, basal estradiol and basal LH.
AFC and AMH.
Yeah, we all know that AFCs and AMH, both of them are the best predictors, best representative of ovarian reserve. And we all know that AMH does tell us about how the patient is going to respond. Okay. Which ovarian stimulation protocol is recommended for predicted high responders to ensure safety? One, long GnRH agonist protocol. B, short GnRH agonist protocol. C, the GnRH antagonist protocol. And D is the modified natural cycle protocol.
Antagonist protocol.
And we all know that the antagonist protocol is the safest because of the advantage that we can always use the GnRH
GnRH analog,
yes,
GnRH
and
agonist.
GnRH agonist we all know causes luteolysis, and the possibility of severe OHSS is almost none.
Minimized.
And of course, you are going to freeze all.
Yes, sir.
Yes, sir. Segmentation of IVF for
Yeah.
prevention of OHSS.
Triad of antagonist
Because
cycle.
nowadays we have this thing called as OHSS free clinics. So
Free clinics.
Right.
yeah, so we have to,
freeze all this.
be a freeze all strategy. Yeah.
For oocyte donors using GnRH antagonist or progesterone protocol, which agent is recommended for triggering final oocyte maturation? 1. A. Recombinant HCG. B. Urinary HCG. C. GnRH agonist. D. Recombinant LH.
Agonist.
C. Agonist.
The fact that you are using donor oocyte, probably these patients are young, they have a good ovarian reserve, and we all know that using a GnRH agonist, you need not freeze all because you are going to transfer it in the recipient.
Yeah.
So it is in donor. No, I would like to comment that these are patients. Many a times they don't come back to us. So when you trigger, you do the oocyte picker, they're lost for
Get them
follow.
off.
Even if you tell them come back, they'll not come. So better play safe. We cannot
Yeah.
put them at risk.
Absolutely.
Yeah.
Absolutely. And I always tell my residents, you see one case of OHSS, and I'm sure you will think 100 times before you administer HCG, especially in those difficult situations where, you are not really sure the progesterone, estradiol levels are not very high, but when you see the scan, there are multiple follicles, in which case probably you have to play safe by giving a agonist trigger.
And it is not only about the fluid accumulation and that OHSS, it's about the enlarged ovaries which can undergo torsion also. I've seen
Absolutely.
patients.
Absolutely.
Even
Safety of the
with
patient comes
clomiphene
first.
citrate, outside one patient came with big ovaries. I don't know what they had done. And she had a torsion. And she was pregnant also. So we have to keep that in mind.
I have one of my relatives who was a young lady, 25 years, with PCOS. They induced with the clomiphene citrate 50 milligrams. She had multiple follicles, and trust me, she had triplets, and she landed with something like OHS like picture. So moral of the story is, please be cautious, especially in PCOS patients or high responders, about the trigger you use. Now, a serum progesterone level below dash suggests anovulation. Is it A, 1 nanogram per ml, B, 2 nanograms per ml, C, 3 nanograms per ml, 4, D, 4 nanograms per ml?
3.
3 nanograms. That is C, 3 nanograms per ml is the right answer. Bariatric surgery is important for resistant anovulation, and it is recommended when the BMI is greater than 28 kgs per meter square, B 30 kgs per meter square, C 32, D 35 kgs per meter square.
D.
35.
It is 35. Only when your lifestyle modifications has not really helped the patient.
We would like to also tell at this point, Dr. Kedar was also talking, that I am seeing day by day bariatric surgeries going down by these drugs, these GLP ones and Monjaro injections. People do not want to do surgeries now. So probably the anti-obesity drugs are replacing bariatric surgery. One of my friends is a bariatric surgeon. He says, I am now shifting slowly to, giving these injections. Of course, there are certain indications where still bariatric surgery is still done, worrying about the long-term side effects of these drugs. We do not know what's going to happen in next 10 years. So, yeah. Okay.
And also the negative publicity because of one of the famous personalities who died immediately after a bariatric surgery. I think,
Yes.
yeah.
Yes.
Last question. Oh, sorry.
Yeah.
A single dose of CFA, that is choriotrophin alpha, can induce and sustain follicular growth for 4 days, 5 days, 6 days, 7 days.
7 days.
7 days.
That is going to be the game changer, probably in IVF, with one injection on day 2. And then probably you might have to, I think by the time when you will get results about your oral antagonists, where you can probably have a minimal pain IVF or no pain IVF. Okay.
And
With
very
this,
patient friendly, no wastage of time. They don't have to
yeah,
come and take the
yeah,
injections
absolutely.
daily.
That's true. That's
I
true.
mean, it'll be a fantastic patient friendly
And even
protocol.
the cost is going to come down, especially as
Cost will
if you are-
come.
Yeah. Thank you. That was, I think everybody has answered well and done well.
And thank you, Dr. Prashant, for preparing such wonderful questions. And thank you to all the panelists. And best of luck. I think most of the panelists are going for election, Kisar election. Voting will start from 11th to 17th February. And my sincere request to all the Kisar members is please come out and vote for the best candidate so that we can take Kisar to a new level, not only in Karnataka, at the national level. And of course, my dream is to take Kisar and Karnataka to international level. We should have a lot of publications, paper presentations, and we are going to do a fantastic academics next 2 years. And all the best to you all. And thank you, a big thank you to Core Connect Corona Remedies. Shivani, are you there?
Thank you, ma'am. Thank you.
Yeah, a big thank you to our partners, Corona, who in such a short notice provided this platform for us. Of course, Insight Series and Evening with ISARIANS is an ongoing webinar, and we do fantastic, talks here. And last one was on corresponder with international faculty, which was really appreciated. Higher logins we had in that, and in future also after our election results are done, we are going to call upon some good international speakers who publish papers, who can push and motivate all of us to, do research and do publications. And that's where India is lagging behind. And thank you so much. Thank you, Dr. Lavanya, and congratulations in
Requesting.
coming unopposed as chairperson of Kisar.
Thank you. Thank you. Thank you, Dr.
Requesting.
Anu.
Thank you.
And I think all my favorites are here, and especially you. And I think you are the one who's motivated people at the national level, representing Kisar at national level. And I think that's the motivation where we have this time 26 consultants for 8 posts. And I think that's fantabulous. Really, I would really say one screen as all my favorites here. I would wish all of you a great luck to make sure that next 2 years, I want all of you to be there with me so that we do wonderful sessions
All
on
the
Kisar and we
contestants
really
are
make
here.
this more.
All the contestants are here, and
Yes, that's why I said. All of you are good.
and
So
requesting
all the
each
best to
one of
all of
us to
you.
vote for us. Requesting each one of us to vote for us.
I
Yes.
think
Prashant,
Chavez is not going for
Yes.
election. Right,
Prashant,
Chavez?
you can show your
And
face.
Priyanka is not going. Rest of us, all of us.
Prashant,
I don't mind. I think
everyone.
yeah.
there is
Hi,
some problem.
Prashant. Hi.
Hi. I think there's some problem with my camera.
Prashant is my distant relative also.
So thank you. A big
Sir,
thank
thank
you to
you.
Corona, and a big thank you to everyone, all the esteemed faculty members. A big thank you to the delegates who have logged in. We have had YouTube logins. We have had the Zoom logins. Thank you, Shivani. And with this,
Thank
I
you, ma'am.
say goodbye to this to all of you. And I pray that we do better and wonderful programs like this one we did today, and with you, Corona.
Thank you, ma'am.
Thank you.
Thank
Thank
you,
you, Dr.
Anuradha
Anu. It
ma'am,
was
Thank you.
Lavanya
wonderful
ma'am.
having
Thank you
you.
so much.
Ma'am, thank you
No,
so
I think
much.
Anu,
All
it
the
was a
best
great
for your
initiative.
election.
Congratulations to
Dr.
Anu for a
Nagesh
great
is
thing.
Thank
standing
you.
for
Thank you very much.
managing committee. Dr. Satvik is standing for managing committee. Dr. Anu Sadashiv is again standing for managing committee. They are the fresh managing committee. They have first time applying. And Dr. Rekha has been with us for last 2 years, and she is applying second term. And Dr. Sujay is very enthusiastic person. I remember you in that IUI workshop, how much you helped us. Dr. Satvik, you arranged that IUI workshop, and it was fantastic under Kasoga. Dr. Shilpa, of course, she's a dear friend, and we need such people, good leadership quality. Dr. Prashant Adiga is Manipal head. I can't say more than this. All the best to you, and it will be it will be so good to have you on board. And Dr. Rashmi Yogesh is also contesting. So all the best. And I'm contesting for Secretary, Karnataka chapter. I hope I get all the support.
Yes.
My humble
We
request
all
to all
support
the
you. We
ISARIANS,
all support you.
please vote for
We
us.
will support you. All the best. Thanks for this
All-
fantastic
Thank you, ma'am.
webinar. Thank you.
All the
Bye-bye
best.
and good night. We
Good
leave
night.
this webinar now. You can stop sharing this corona.
Thank you. Good night.